Hi, I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and HealthCareCAN podcast serial where we dive into healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. If I were to say the words health information, what would it mean to you? Do you imagine patient charts or information that you find about yourself online? Perhaps the better question is, what does health information mean for each of us and to our health system? The information collected and stored in our personal health records is one of the most valuable assets within healthcare. It's why hackers and cyber criminals increasingly target our healthcare organizations and systems. It is used to provide patient care when a physician or other clinician looks at a patient's chart. It is used to improve quality and safety of care. It is used to conduct clinical research and learn about the efficacy of treatments and technology. It is used for decision making and funding at an organizational and system level. And of course, during our pandemic, health information, not just the numbers in the spread, but who got what shot and when and what happened, has all been critical to make public health decisions. But have you thought about how and by whom that data is put into charts and databases every day? Back in the 1950s, health information was managed by technicians called medical record librarians, and no word of a lie, many of them worked in the basements of our hospitals where these paper records were filed and archived. Over the years, medical record librarians evolved to become health record technicians and administrators, and eventually health information management professionals who engage in at least 2 years of formal education and must become certified through a professional college to practice. I'd argue that many of us working in the health system aren't aware of these professionals and the important work they do to support the effective collection and use of high quality health data and information to protect its privacy, security, and integrity. And I'm pretty sure that if ICD 10 came up on a Jeopardy screen, even most healthcare professionals would get the question wrong. So, who are these unsung health professionals? And what is their role in not only our current health system, but in shaping its future? How does this information get used, and why should we care about the quality of it? And with the increased use of technology in all parts of our health system, how will this impact the profession? To help us answer these questions, I'm joined by Monique Rasmussen, Regional Director of Coding and Informatics at Providence Health in British Columbia, where she also manages all the coding resources, data quality analysts, and clinical documentation specialists for all of the health authorities within the lower mainland of BC. With more than 27 years of HIM experience gained between Ontario and BC, Monique provides leadership and strategic direction to not only those organizations in BC, but to the rest of Canada, as Monique is also the current chair of the board of the Canadian Health Information Management Association, which accredits the schools that teach HIM and also certifies those that work in the profession. Hi, Monique, and welcome to the HQ.
Hi, Dale. Thanks so much for having me here today.
It's great to see you again. And I'm really looking forward to having this conversation about something I think a lot of people really just probably take for granted and just sort of don't really know how it happens or where it happens. So maybe we could start with what your definition of health information is and why is it important?
Sure. So, when I think about health information, I just think of everything that impacts the patient journey from, being registered, coming into an acute care center in a hospital, being registered by registration staff, moving through the journey, the documentation in their record, the creation of their record, the documentation in that record, then the distribution of the patient information, after the patient's left the hospital. But that goes on to talk about patient care, of course, in the community and follow up. And then also the coding piece, which of course is sort of my subject expertise and sort of the world that I live in right now, just about the coded data and the impact that that has, on research, national benchmarking, funding for the hospitals. Um, yeah.
So when so you use the word coding, and I know that that may be confusing to a lot of people because when they think of coding and in our common vocabulary, they probably think of people who create video games and other kinds of computer sides of things. So what does coding mean in the context of health information?
Right, exactly. Yes, I actually get those questions a lot when I explain what I do to people that I meet. So it's definitely medical coding, not computer coding. So it's basically taking, the information in a patient's record, more so the diagnostic and interventional, so procedural information in a patient's record, and translating that to alphanumeric codes, which are called ICD-10 and CCI for the intervention piece. And that information, that coded information is actually sent over to CIHI, which is the Canadian Institute for Health Information. And that information is used by CIHI to provide reporting to provincial, like ministries of health, federal bodies, also back to the hospitals. And it's used in calculations for patient funding and national benchmarking.
So if I understand correctly, so that a lot of that information gets, I guess, aggregated by Kai and then is used to sort of tell the story about what's happening in Canada, or
Exactly. Yes, that's exactly it, Dale. You totally have it correct. That's to tell the story about, what's happening with the patients in hospital settings, um, and what their healthcare journey is like, the resources that are being used. Um, Sorry, I've lost my train of thought.
it's okay.
um, Yes, basically, it's used to talk about what's happening with patients in hospital settings. What their diagnoses are, what procedures are being used, what the cost of these hospital stays are, length of stay, so how long patients are staying in hospitals, and so forth.
And so, and why is that, I guess, important back to the organizations, like, so back to Providence Health, where you work? Where does that information, like, how does that translate, I guess, into the way they deliver care or the rest of their operations?
Right. So it's used for planning, of course. So for bed management, for resource utilization. If I can give you an example. So when
Hmm.
data is submitted in terms of emergency cases, so how many patients are seen in the emergency in a given fiscal year, what their diagnosis are, procedures, things like that. When the hospitals look at this data that comes back and see that they do not have enough beds to care for the patients, that's when they start talking about redevelopment and creating larger hospitals, like for bed space, and also the services that they provide. Are they accurately providing the services that the patients are needing that are coming to the hospital, right? So that, do they have enough equipment? Do they have enough specialties in that a hospital setting that are dealing with those complex patients that are coming to see them? So it's really all about planning, resourcing for the hospital, bed utilization, making sure the hospital can deliver that great patient care, and using the data to help provide the story about what's happening really when people are walking through their doors and receiving care and service.
Okay, so that's helpful. Uh, and you talked a little bit about sort of, and I think I mentioned it at the beginning in the introduction as well, around so you said the CCI side of the ICD-10 component. So uh, maybe you could sort of dig into that a little bit deeper for us as well, how that information gets used in our health system.
So that information is also submitted to CIHI, right? It's all submitted as the patient we call it the patient abstract in coding terms. That's all submitted. It is also reported back from CIHI to the hospitals, to the ministry, so that they do understand to what procedures are being done on patients in the acute care settings. And again, for planning purposes, right? So, and also in terms of maybe just length of stay, right? So patients that have particular procedures, so say a hip replacement, joint replacements,
Hmm.
there's data that's collected on that and put in specific databases as well, just to sort of track and follow what's happening with joint procedures within Canada. And this also leans a bit over to length of stay. When people are coming in for scheduled procedures, there's a certain, type of formula or expectation that a person with a certain diagnosis, like a hip replacement, will be in hospital for, say, 3 to 5 days recovering, maybe less than that now, actually, maybe 1 to 2 days. Um, so that's the expected length of stay. But then when something happens to the patient, say they develop, heart like palpitations, or they develop some other post-admit comorbidity where they become sicker, all of that data feeds into those calculations about what's happening to the patient. So a patient that came in for a routine hip replacement that actually becomes a little bit ill, that's also reflected in that coded data, and that changes, funding formulas, that changes the reporting piece of it. It changes maybe planning, and it gives the acute care, the clinical staff insight onto what's happening with some of their patients, that are supposed to be sort of routine procedures, and things happen after that procedure is done.
And so would it make a difference as well, I guess, in terms of, I guess, planning, even like, I guess, how we do our clinical care? So I think in describing what you've around the hip replacement, for example, if a certain kind of procedure is performed on a patient and something happens to that person thereafter, it just seems like it's a story of one person. But
Mhm.
if that same procedure is performed to 20 people across the country and the same unexpected outcomes happen to those same people, would that then translate into the way those codes and that information's being used for us to learn about that, or about the efficacy of something, or not?
Yeah, so yeah, you've gotten to a great pathway to talk about hospital harm, and yes, those are instances and data that we capture too. Hospital harm, there's a CHI framework where they've outlined a specific amount of diagnosis. I'm going to put myself on the spot. I think it's 27 um, hot, diagnosis where patients, this happens after they're admitted. It's called, and it follows along that hospital harm framework. Our teams, the teams that I work with at Providence Health, we do some work with patient quality and safety departments, and we look at hospital harm indicators, and we look at hospital harm data, and we help sort of support the clinical staff as they're going through those reports and trying to understand what happened to the patient, and looking at those charts, and just to understand how maybe some of these cases, well, sort of some of this hospital harm can be prevented, and how, so all of that documentation, all of that coding feeds into all of those conversations. And this is, of course, where the hospitals are able to pull out those particular visits, and those particular patients where that could fall under those hospital harm indicators.
Okay. And we would also, I guess, learn about um, the kinds of devices that might be used as well. Like, I think if I've heard correctly, that in some joint replacements, you might be using materials like, or maybe plastic or metal, or different kinds of metal, or different kinds of approaches to that, and which ones are working better over time, or would that be fair as well?
Yeah, so there is a joint registry. And again, you're testing me a little bit because I haven't coded in a long time. So there is a joint registry where information like that is documented. So, the part number and the hardware number and sort of
Hmm.
the serial numbers, that's all documented and, of course, submitted and kept in a database. So when there is incidents of, I don't know if they call them recalls, but where equipment is, they've understood that maybe some equipment isn't working as it should be. So there is those areas where things are tracked, again, this is all about ongoing patient care, right? Because the last thing you want to see happen is somebody comes in for a much needed hip or knee replacement, and then have the hardware fail. So, and this is, again, is all part of the information that's collected by health information professionals across the
Yeah. So
country.
yeah. So I guess that's where I'm trying to go back to then. That If we understand, I guess, the importance of this information and what's being captured, so let's talk about the people who are doing it. I mean, who are these people and where do they work? I think if I was to go through a hospital, I could probably point out a lot of the people who work in a hospital based on their uniforms or their equipment that they're carrying. How would I know? Like, would I see a health information management professional or, yeah?
Yeah, quite. Well, you would see health information management professionals, not coders per se, but you would see them in registration staff. You know,
Hmm.
you would see them in unit clerks. They can be considered health information management professionals. But the coding staff, which again is sort of my portfolio, they're typically working away in the background, very busy. But you wouldn't typically see them unless you came into a health records department and you saw some people maybe working diligently at computers looking at records and things like that. But I had a bit of a giggle when you talked about back in the day, health records, people were notoriously kept in the basement, sort of away from the public, and I think that's still kind of true in some hospital settings, but I feel like we're coming out of the shadows a little bit. Um, but they really are. I did have somebody, one of my colleagues that actually sits on the team of board with me, she often calls HIN professionals unsung heroes. And I totally agree with her because they are the people that are so knowledgeable when it comes to pathophysiology and medical terminology. And they're so knowledgeable about what really goes on with the patient during their stay because they are reading all about the patient's most intimate health information, which is in their patient record. So they really have a great understanding of all of the pieces that work together in a hospital that affect the patient through their journey. But they are very much working very quietly in the background. I would say when I describe a coder, I would say definitely people who are very detail oriented, who are very passionate about making sure that they are doing the best job that they can to reflect what's going on with the patient. I would say their critical thinking skills are fantastic,
Hmm.
um, and very typically very quiet and very yeah, just very quiet and calm, quiet people who just are really interested in I think the medical field, and that this is where they find that they can provide the best service um, to the healthcare organizations.
I, I'm certainly struck by their access to the information about the intimacy side of it that you described there. Um, I know that in this podcast people can't actually see, but I mean, but how big is a typical patient chart? How many pieces of information or pieces of paper might be captured in that these people are sort of being able to read together?
Yeah, so it varies, Dale. When you think about so an emergency record, it could be just 5 pages, right? If it's sort of an in and out, you cut your finger, you need a suture. Or if you come into the emerge and you're having a cardiac arrest, then the paper starts to grow, right? And then you're admitted. And that chart, you move through the system where you're having lots of diagnostic procedures and interventions, and there's lots of nursing documentation, consultant notes. If you have a surgery, there's the entire OR package where you have the consents and you have the anesthetic records and the OR reports, and then you have all of the physician follow-up and progress notes, and then the discharge information. And if you have any other allied health that come in, say like a respiratory therapist or a physiotherapist, occupational therapist, all of those specialties and people that touch the patient have to keep a note, a record, right, of what they've seen, of what they believe the treatment should be. And then you can talk about mental health too. There's a lot of documents that are kept on people that are mental health patients. There's lots of information. So the chart can basically go from 5 pages to a few hundred, depending on length of stay. There's also not so much the acute care side, which I talked about, but then there's chronic patients, that are in long-term chronic sites, units like within the hospital or rehab. Say somebody has had a stroke and they come in through emerge, they're admitted through the acute side, then they go to rehab for say 6 to 8 weeks recovery, where they have to have lots of um, work with physiotherapies and occupational therapies to as part of their recovery. So it can get quite large. Thankfully, we're kind of moving out of a paper centered world for the patient record, and we're moving more over to electronic records, which is nice. But for HIMs who still have to go in and review the chart, they're still looking at lots of documentation, whether that be on paper or in the electronic format.
Yeah, and I guess, and they're connecting the dots, right? I guess if
Yes.
where you've just described in some of those kinds of patients, right? I mean, they've maybe been touched by 20, 30 more kinds of clinicians along the way. And while they may read each other's notes to some degree, probably not in the same level of detail that the HIM um, might be working with, so that they are telling that story, I guess, in a different kind of way or reading it differently.
Yeah, exactly. And I think too, there are definitely sort of source documents that coders look at, that are sort of the big documents that talk about most of the care. But a lot of times there can be conflicting documentation in the charts. So that's where the coders have to sort of be those put on that investigation hat where they have to go in and either look for more information that gives a more specific piece to the diagnosis. Like,
Mm-hmm.
so diabetes, for instance, if they want to know if it's type 1, type 2, they want to know if there's any complications with the patient. That's not always so easily outlined, say on the discharge summary or maybe the admission record. So they sometimes have to go through the chart just to get a bit more specific, to be able to assign those codes, those ICD-10 and those procedural codes, to actually make sure they're getting the most specific code that they can get. So again, so the quality of data is there, right? It's all about quality data and making sure that what happens to the patient is accurately reflected in those codes.
Yeah, so I think as you've described to investigate, I had an image of my head of the like a detective, I guess, going to a crime scene, a forensic sort of investigator who's looking at all this different the clues and pieces of information and trying to tell a story about what happened before they got there. Would that accurately describe a little bit of what you're sort of describing, or?
Yeah, I would say so. I mean, and depending on the quality of documentation, how the clinicians are how good they are, basically, about putting that information down, either through a transcribed report or actually handwriting the information. In cases where I'll bring back like the cardiac arrest example, when clinicians are there to treat the patient, right? That is their ultimate first and foremost responsibility. So when you have somebody having a cardiac arrest, and all this information has to be documented in terms of times and the procedures that they're doing, it can get a bit kind of messy, in the charts when it comes to documentation, and a bit conflicting. So that's where, you have a coder they're basically a SME, a subject matter expert, when it comes to looking through the chart, and they know what they need to capture in terms
Mm-hmm.
of guidelines and standards when it comes to coding. So that's where, yes, they are like a detective, and they're trying to put those pieces together again to make sure that they're accurately reflecting what went on with that patient in that situation.
Interesting. So these CSI type of people in the world that many of don't get, are the unsung heroes as you described. So I mean, how does it feel for people like yourself and your colleagues, I guess, to be unsung or perhaps even unseen in terms of your day-to-day work? I mean, does it change the way you feel about yourself or the way your colleagues feel about themselves in terms of their contributions to healthcare and our systems?
I think for the most part, the HIMs that I know are so humble, right? And they just believe they go to work and they do this job, and they understand their impact to the healthcare system, but I don't think they're looking for a prize at the end of the day, right? I think
Hmm.
they do it because they know the importance. They know when they come and they sit down and they open that chart, and what they're collecting and the bigger impact it has on the healthcare system. They know that, right? So, but I think they're so humble in so many ways, and I see that with every one of them that I meet. That um, I don't think they look at it as just a job because, like I said, they
Hmm.
understand the importance. But I don't feel like they often get enough credit for what they do, right? And I think, when the hospitals report data, usually it doesn't really come from typically, and I'm just talking about my world, of course, we have decision support departments that take our data, like the data that the coders collect, and they're the ones that distribute it to the physician groups and to like the senior leadership teams and to anybody that's coming and asking for data. So I often find that it's maybe the decision support teams, I don't want to say get the credit, but maybe the hospitals look at them as the people that are doing all of this work, and the coders and the people that collect the data are often sort of behind. Those people working quietly and diligently. So I think it's yeah, it's and often when you talk to HIM, it's often people the comments are people don't know what we do, people you don't really understand what coding is and the impact that it has. I do feel like, though I mentioned before, I feel like things are starting to change a little bit. I feel like and again, just talking about my world, especially with the implementation of the electronic records, I feel like HIM is at the table. They're in those big discussions. They're helping with design of those EMRs and EHRs. They're helping with implementation. We're getting more people within HIM that have those systems background, that those ability to help build interfaces, do data validation. So it's coming. I think it's changing, and we're finding that, but we still have, I think, a ways to go. And then, of course, you mentioned at the beginning of the podcast when you introduced me that I do sit on the board for CHIMA, the Canadian Health Information Management Association, and I think we've come a long way in the last few years where there's been a lot of work done by the organization to sort of lift up the HIM profession and talk to broader groups, sort of even outside of healthcare, just to talk about what health information is and who these people are that work in the background and do all of this work and the skill set that we can offer. And I think we're starting to see health information professionals start to broaden outside of healthcare and start to work in places like insurance offices, working in organizations on privacy, which is sort of outside of the typical registration clerk or coder or transcription role. So I think things are starting to change, but I think we still have a long way to go.
Yeah, I mean, I've certainly heard stories from hospital administrators and things describing um, when health information management professionals get things wrong, or in their opinions get things wrong. It costs them money, or uh, puts them in the wrong public light in terms of their performance. With that sort of, I mean, is that accurate?
um, Yeah, I would say that's accurate. And it's always sort of a touchy subject, right? When you're talking to the group that collects the data. But yeah, that is unfortunately kind of a typical response is when, the like senior executives are looking at data and something isn't wrong where there's money, funding hasn't come in, or there's been, even not so much sometimes about the money, just but about how you said, like the hospital looks like maybe they've got an overabundance cases of harm happening. So yes, the first point of contact, that's when they remember what coding is, right? So who's collecting the data and what does this look like? And of course, and that does happen. I mean, in all honesty, that does happen. And but there are work that happens after that to start doing chart reviews and start working with like quality teams and start working with decision support teams and start working with clinical teams to start talking about clinical documentation improvement, because the coders can't make it up, right? So if the coding, as hard as they try to get the quality great, we can't make it up. So really the documentation has to be great as well. And it has to be fulsome, and it has to be accurate, and it has to be timely. And that's another thing too, that maybe I could talk about a bit too, is, when a coder is trying to finish off, period end and physicians haven't come in to either complete discharge summaries or OR reports, which are vital documents in the coding process, um, it gets really difficult, right, to get that accurate data. And
Mhm.
we have found that more times than not, that typically when there is a problem with the coded data, it's because the documentation is either missing or it's inaccurate, or it's not fulsome, right? Like there's just not enough to go on to actually provide that true picture of what's been happening with that patient or
Yeah.
patients. Yeah.
Yeah, so it's definitely a team sport and
Mm,
the garbage in, garbage out sort of approach to
exactly.
things. Yeah. Um, so maybe just talking a little bit about the future of the profession, Monique, and uh, you've talked about the technology that we're moving away from paper. Like there's more digital records and things like that, and other kinds of changes within healthcare. Could you talk a little bit about what the future looks like with all of this change?
Sure. So a little bit that's happening in my world too. We're always looking at technology, and not, maybe I should preface this, Dale, by saying not as a way to eliminate staff or coding or people. That's definitely not the goal. The goal is to actually, use technology to kind of take the burden off of a lot of some of the work that the coders do, and even other areas of HIM. But one thing that always, a couple of things that always come to mind when people ask me about technology is computer assisted coding. That seems to be sort of a hot topic.
Hmm.
In the coding space across Canada, and we know it's been really computer assisted coding has been used in the United States for many years successfully. So that is one thing that we're really looking at in Vancouver and like BC is a implementation of computer assisted coding, and that again is a way not to take away coding staff, but to actually help coding staff with being able to. So what computer assisted coding does is it's a piece of software that sort of runs in the background. It has a natural language processing, so it uses NLP, and it basically reads through all of the electronic documentation in the patient record, and it annotates, so it highlights key diagnostic terms and key procedural terms, and
Hmm.
brings it sort of to the forefront of the document for the coder. So the coder, usually is reading, when they're reading electronic documentation, it's black and white, it's not very pretty, but this annotates and highlights in different colors. So it actually pops it out for the coder. So when they're scanning the documents, they can they can pick up on these terms quite a bit quickly. It also offers what's called a coder view. So documents can be brought in from the large electronic record and brought into the CAC space. And it kind of gives a coder view. So all of those key documents that coders need to look at, it gives them sort of a one shot view of all of those documents. So it makes it quite easier to navigate to get through all of that information. So that's where their hope, the hope is that you see like some productivity gains. You also see some maybe improvement in data quality. You take a bit of the burden off of coders so that they can maybe start working. Their roles can change into other areas such as doing more data quality, um, and things like that. And then the other piece that often we talk about, just in my world, when we talk about computer assisted coding, we also talk about CDI, which is clinical documentation improvement,
Hmm.
and how there are software programs that sort of stack onto the CAC that can help with the clinical documentation improvement work that we also do. And those are things like, so clinical documentation. When I talk about that, I talk about the education of physicians to teach them sort of how to document well, what sort of things are needed when you're coding, the impact of poor documentation and what that potentially has on coding and funding and all of those other things that we've talked about. So we actually look to moving towards some clinical documentation improvement software as well that sort of tags on to the CAC. And this is to be a bit more proactive when it comes to our CDI work. Right now, we spend a lot of time doing doing reactive work in terms of there being a problem with the data. We go back, we pull charts, we do manual chart reviews, we sit with clinicians, we sit with quality teams. The CDI tools are meant as sort of real time documentation improvement reviews of charts, sending real time notifications to physicians to say this documentation is conflicting. Do you actually mean this or do you mean that? Looking through say lab values and saying these lab values that come back, it looks like the patient could have sepsis. You haven't documented it. Do you wish to? So it's things like that where all of that technology is helping again for the broader um, for the broader. Sorry, I lost my train of thought. What I'm trying to say is all of that technology eventually helps with all of the coded data, the information that's in the chart, and then ultimately for patient care, right? Because if the documentation is good in the chart, the coded data is correct, but then when that documentation is moved out into the community and it's used by practicing physicians in the community for follow up, they have an accurate picture of what's been happening with the patient in the hospital.
Yeah, so I guess the proverbial that technology or machines are going to steal our jobs, or the jobs in this case of health information management professionals, is not inaccurate at all. It's simply it's improving the way they work, making it easier, reducing those 200-page charts into more meaningful pieces of information that still need a person to read them,
Yes.
and find the right pieces of information. So
Yeah, correct. You still need that human touch and that, those critical thinking skills. And yeah, you've got it exactly right, Dale. And it's basically what we call just another tool in the toolbox, right? It's like having the coding standards. It's having, like having another piece of work that we've been doing a lot on is sort of beefing up our interfaces. So, adding more, when you get into an electronic health record, there's more information that you can pull from the electronic source and bring into the abstracting system so the coders they don't necessarily have to keep coding that information. They just have to start verifying. So the roles are kind of changing too from, yes, they still need that coding skill set and that foundational knowledge of coding, but then they start doing some of that validation based on some of the electronic tools and work that we've been doing to get the information into the coding system.
So you talk about these changing roles. So how does that impact, I guess, the way you recruit, retain, train, manage your staff? I mean,
Mm-hmm.
in some of the previous episodes on the HQ, we've talked a lot about the current HHR crisis and the challenges of finding people.
Mm-hmm.
And so maybe you could talk about that too. I mean, are you seeing a challenge in terms of getting people to do this job? Do you have enough? And again, how does it change sort of going forward in terms of the people that you're bringing into the profession?
Yeah, it's a good question, Dale. And yes, definitely, we know that there's a huge recruitment challenge across the country when it comes to qualified health information professionals. Maybe just your first question there in terms of roles changing, especially with all of this sort of technology coming. I think, to be honest, I think the schools are doing a great job of starting to write some of that into their curriculum, where the students are coming out and they're starting to have a basic understanding of what's coming up with technology and what computer assisted coding is, what clinical documentation is. So I think some of the new graduates are really starting to understand, and they have a bit of knowledge. So that's great when we're
Hmm.
starting to hire people. The other piece is and again, just talking about my portfolio, we do have data analysts and sort of data quality folks and in my portfolio and clinical documentation improvement specialists. And what we tend to find is our coders, after they've had a few years of coding behind them, some love to stay in coding and that's great, but some like to move on. And so they take some education on the side, they take some courses. We actually train them a lot in-house and they move into these data quality roles and clinical documentation roles. So it's a lot of kind of homegrown where you sort of
Yeah.
promote within and we also try to share a lot of the work that all of our different teams do with each other. So we try to, show our coders what the data quality team does, what clinical documentation is, and vice versa. Like, so we try to really have that culture of we love to promote within, we love to foster and mentor growth within. So that's how we're kind of managing that. I mean, it's difficult too, right? Because sometimes you don't always get people that want to move around. So that's how we've tried to manage that a little bit. In terms of recruitment, yeah, we do. So in the Lower Mainland, we're quite. Maybe I could talk about this just quickly. We're quite lucky because we do have a Douglas College in the Lower Mainland, and we do have a great working relationship with them in terms of supporting practicums. We actually also have a paid co-op education program with them, so we do take co-op students. In their last semester, and we bring them on site and have them start to code day surgery charts. We train them up, and then we tend to hire from the college, which is great. But I know that not everyone has the luxury of being so fortunate to have a school so close and to be able to have those relationships. So um, it is quite difficult. There's quite a struggle, I think, still out there. Um, I think too there are more colleges sort of popping up across the country too to teach the HIM program. I think colleges too are getting a bit more flexible in terms of teaching virtually as well. So because not everybody can move, right? Some people. Not everybody can move to go to school, and then of course there's institutions like yours where it's very flexible in terms of you could have somebody working um, already in the healthcare space that just wants to either get some more education or go into it maybe a different role. So you're offering those courses virtually, which is really really helpful for people. But yeah, there is it's definitely on the radar, I think, for a lot of folks that there is, we're at that stage where we do have a lot of people retiring out of
Hmm.
HIM and maybe not so many people coming into HIM. And I think, another good strategy is actually just spreading the word, things like doing these podcasts and actually explaining to people what HIM is, right? And because again, we've said it probably 40 times already, people really don't know who we are. So, just sort of getting out there and promoting the career and promoting what it means and the impact it has on the whole healthcare system, I think is helpful. Did I answer your question, or I feel like I
Yeah, yeah, I
just
think so.
off a little bit there?
One, I guess, to wrap a few things together here, it's not a disappearing profession. It's an evolving profession, perhaps, is one way to say it. Um, and um, yeah, I guess that computers and AI aren't stealing people's jobs. And the way the system is changing, that there's more demand for this profession than there's ever been, except, the use of technology perhaps is going to be more integral to how people are working going forward. Is that,
Absolutely. Hmm.
yeah?
And I
Um,
think,
yep, sorry.
okay. Oh, I was just going to mention just one thing too, when if you want to talk about sort of data use and how it's becoming quite a bit more prevalent, that timely data and lots of data is really needed. Could talk a bit just about the COVID pandemic and how that changed a lot of our data collections and how we in the province of BC, we were able to actually report COVID cases um, every week. We were reporting, what we were seeing in the hospitals and in the emerges. We were reporting that to CIHI and the ministries on a weekly basis, which is sort of not the way we work, right? We work on a period by period basis, but we were able to sort of stand that up quite quickly and do a lot of data quality and validation in the back end. And we were reporting for actually quite a long time, over a year, just those COVID cases, and that was really helping the province and the Ministry of BC with their planning and understanding what was happening with the folks right throughout the province with this awful pandemic. And we've actually just stopped that reporting just recently, I think about 2 or 3 months ago. So that was just kind of one example where just to sort of tie this whole conversation together, where the impact of the coded data and the work that the HIM professionals do and how valued it is and how vital it is. Like this pandemic has shown that, quite a bit. So
Yeah,
just
and
want.
and that's exactly actually where I wanted to go next with the question too. Is the real time use of the data? So I mean, in terms of the discussions about Kai and other organizations like that use the data, a lot of it is, I guess, retrospective and more longitudinal. But I think the example you used with COVID, I think, is a great one around data being used in a real time sort of scenario to change more immediate plans. Is there other ways that it's changing the way, the operations within a hospital as well, in terms of your clinical staff and the way that they're delivering care based on the work of yourself and your team?
Um, like in terms of real time data, is that what you
Yeah,
mean?
yeah.
Yeah, we don't really, it's difficult. We don't really provide a whole lot of real time data outside of what we did for COVID, to be honest. We don't do concurrent, like what we call concurrent coding. Um, our NACR, so our ED reporting is done quite quickly. But really, in terms of like the DAD or the acute and the surgical daycare, we basically aren't able to do a lot of that in real time because we have to wait for the patient to be discharged, the reports to be done. It's kind of unfortunate, and I know that I've been involved in many conversations about what they deem like concurrent coding because they want the data quicker and faster. And
Hmm.
um, it all has to come together, though. That's the problem. It's not just the coding staff that can make that happen, it's the clinical workflows as well that need to be in place to allow that to happen, and that's just not there yet. um, and so those conversations, with the all of the projects going on with the implementation of electronic records, sort of in all the organizations that I work in, that those conversations have basically been put on hold because we need to get that done first, and
Yeah,
then we can start looking at ways that the electronic record can help. Perhaps we can use that to leverage, more real time reporting, more concurrent data, which eventually is, I believe, where we would like to get to. I think that
yeah,
would be such a win win, right, for everyone in the
yeah.
healthcare system.
Yeah, it makes sense, and
Mhm.
and maybe that will be one of the lessons learned from, I guess, COVID and the pandemic in terms of how data can be used more meaningfully in that space. So, um, we'll
Exactly.
see. Yeah. Um, Maybe just as we sort of get ready to close here, Monique, just other changes, I guess, that may be changing the profession. I do wonder around like the way, even my own personal experience in terms of how I go to the doctor and, through patient portals or getting my other information, real time in front of me. Is that going to change the way uh, your profession works, or the way health information continues to work, I guess, more broadly speaking?
I think so, Dale. I think it definitely could. I mean, I think a lot of organizations are looking at patient portals to support that patient, those patient asks, right, for sort of, they want to come in. They don't necessarily want to come on site to get their documents, right? Their actual papers. They can do it from the comforts of their own home, and then they can actually just have the information sent to a physician, right? And that's all about leveraging, those technologies that we're putting in place. I think it will change. In a great way. I mean, I think there's always that privacy component as well, about, health information like custodialship, who owns the record, who owns the information, how that's disseminated. I think all of that, comes into play. And I definitely know that that's on the forefront of the discussions, of course. But yeah, I can see it changing significantly. And I think that's, of course, what we all want, right? Is like we want things to be more accessible. We want people for their follow up care in the community to be timely. And that's how you just keep the population healthy, right? So I think there's definitely changes coming. I think for HIM, there's a lot of involvement in those conversations. Again, being, such a, on the registration and records management side, being so involved in that work, the HIM professionals are the subject matter experts when it comes to the information, how it's collected, how it's disclosed, released, all of those privacy laws, regulations, rules, however you want to frame it. There is definitely room for HIM at those tables and for that work. And It's a good thing. It's all a really good thing to help the patients with their ongoing medical journey just outside of those four hospital walls.
Yeah, and maybe an opportunity for these HIM professionals, these unsung heroes, I guess, to come out of the shadows a bit more as well and be seen in
Yes.
terms of their value and their contributions to, you know, my experience.
Yeah, I love that, Dale. You couldn't have said it any better. It's great.
Very good. Any other closing words then, Monique, in terms of what we can do to help share the word and give this profession some of the due recognition?
Yeah, just thank you, Dale, for having me here and sort of let me kind of ramble on and talk about, my work world. I'm very passionate about HIM. I've been here a long time, and I just think, yeah, if you have the opportunity to talk to somebody and say, "Hey, I listened to this really cool podcast. Did you know that this happens behind the scenes in the hospital? Did you know when you go to the doctor and you get that report from you've been into the hospital, what happens with that actually? And do you know how the hospitals are funded?" All of those kind of insightful questions. So I just really appreciate you being here and letting me share a little bit of a glimpse into the world of HIM.
Yeah, no, my pleasure, and I'm very happy to be able to share this important part of our health system with our listeners. So, thank you very much for taking your time today to share with us that story, and wish you the very best.
Great. Thanks, Dale.
Okay, take care. You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.